So, welcome everybody, and belated happy Easter. Just a reminder to everybody that this is a meeting in public, not a public meeting, and that we've moved to meet online rather than face to face because of the junior doctors strike that began today, and we'll hear a little bit. We'll hear a little bit more of that from Steve O'Meara shortly. We've got apologies from Joe for the earlier part of our meetings today. She'll be joining us later on in the day. Steve will cover this morning. Vicky is away, but we say welcome to Sarah Hewson-Grubb, who has joined the Trust as Deputy Director, and I can't see her on my screen, but I hope, I'm sure Sarah's with us. She'll cover later on. Thank you. So we've got some members of the public in attendance. Nice to see Liz back after an extended absence. I'm talking about you, Liz, as though you're a member of staff, which I realise must sound a little bit odd, but you're an old friend of the trust, if I can put it in those terms. So it's nice to see you back. I think Bruce is joining us. I'm not sure whether he's made it or not. So there we are. So we've got a truncated meeting this morning, partly as a consequence, mostly as a consequence of the strike. So we will go through items at a bit of a pace, more so than we would perhaps normally do. So so that's item 1 covered. Let's move to item 2, staff recognition, and you'll see from the papers that our January winner was Raj Sharma, the medical examiner from bereavement service, and you can see from the papers the many and various tributes that were paid to the work that Raj has done. I'm meeting with him either next week or the week after, I think, which I'm very much looking forward to. There are some long service awards there that you can see, and in particular I wanted to say thank you to all of those who were named for their contribution over the years, and in particular to Ruth and Debbie, who've done 40 plus years. So very many congratulations to them, and our thanks both from the board and I think from patients and their colleagues. We've got no declarations of interest, so let's move, no new declarations, I should say. Let's move to the minutes of the 14th of February. Can I check, first of all, whether colleagues are happy that they are an accurate reflection? And
Chair, if I may, I've sent a couple of admin tweaks to Pete late last week, but also in relation to the section on the BAF, I think as part of that discussion, Richard, Damien, correct me if you're wrong, we discussed the fact that I was concerned whether the BAF really represents where we are as at now and looking forward. And Richard, I think you're going to take it away and consider that and reflect on that. And I just want to make sure the meeting minutes reflect that, Chair.
Okay. Richard, you happy with that?
I'm happy with that. That's no problem at all. Thanks, Chris.
Right. Any other matters for accuracy that colleagues want to raise? No, if not, I'll, with that one amendment, we'll receive those as approved. There are no formal matters arising, but I wanted to see if colleagues had anything that they wanted to raise. Gone. Okay, thanks very much, everybody. So let's move to the committee chair's feedback. We've got the report on audit. Paresh, anything you want to add?
I'll take the paper as read. And the only thing I would like to add to that is basically the finance team now is working very hard on the year-end auditing process. So they are kind of credit to them for preparing all the work to date. And the other thing to note is that we've now appointed RSM as our internal auditors after a competitive process whereby TIA unfortunately didn't make it through the cut. So they were in a standstill period. I think that period is now over, and I think RSM are now formally appointed. Damien, correct me if I'm wrong.
Sorry, you're right, Paresh. So.
Okay, that's what I wanted to update the board on.
Thanks, Paresh. Any questions for Paresh? Gone. F&P, it says Nikki here, but that would be unfair to ask you to comment on those, Nikki, given that you weren't there. I think the notes capture the points, so I'm happy to open it for questions. Anybody got anything they want to raise? No. I should say Karen is desperately trying to join us. She finds herself in rural France where she wasn't expecting to be, where the internet connection is not quite what she would want, and she keeps trying to join, and I think Ben just keeps. I think the signal keeps dropping out. So, so that's that. Pod, Karis, anything you want to add to the note?
No, but open to answering any questions.
Thanks. Anything for Karis? No. Okay, thanks. Quality and safety, Amanda. A bit of a cut and paste problem at the beginning.
Yes, a minor problem, Chair, with the pod reference at the beginning, but the content stands. And just really, I'd like to bring out 2 points, if I may, Chair. One, it was Hazel Tong's last meeting with us. She has retired, and I just wanted to publicly thank her for such a significant contribution to the Trust. She has been exemplary, and obviously welcome Sarah. The only other thing, Chair, was the focus on deconditioning, which has been quite a focus for quality and safety. And there was a workshop from an expert, which is available online, but really worth thinking about how we manage patients who are with us longer than is desired. So those are the 2 points I wanted to raise, really.
Thanks very much, Amanda. Any questions? Amanda, and thank you. And finally, on strategy and transformation, Jackie.
Thanks, Chair. Take it as read. I think just the main thing is the ICP delivery plan now that follows the strategy, and we will have to give that some attention. It will be quite significant for us, and we will have to measure that also against the BAF, which comes, both of those things come back to the next committee meeting. Otherwise, happy to take questions.
Thank you. Anything for Jackie? Anybody wants to raise? Okay, great. Thanks very much, everybody. Shall we move to agenda item 7 and the Chief Exec's report? Steve.
Great, thank you very much, everyone. Good morning. As Steve's already mentioned, Joe is on leave this week, so isn't joining us this morning. So you've got me, I'm afraid. I will take the report as read, so I'm not going to go through anything there. As Steve alluded to, though, I will just give a brief update on what we know about the industrial action so far. We worked really hard last week to make sure we were in a really good position going into the weekend, that we had beds available, that we were doing everything we could to ease into this week as best we possibly could. Our performance over the weekend, I think our ED performance has actually backed that up, where our performance was in the top 70s, early 80s over the weekend, predominantly, which is pleasing. Our discharge lounges are fully operational this morning, and there's a real focus on making sure that we keep the hospital as clear as we can to deal with the challenges that we might face. All of our services are covered this week, albeit some of them lightly. We did have some challenges at the back end of last week with doing that, but I'm really grateful to our consultant colleagues and our trust grade doctor colleagues for the work that they've put into making sure that all shifts are covered. So there are no particular areas where we see ourselves at any significant risk, though inevitably with the lack of junior doctors, assuming that we do see significant strike action, that is going to be a challenge for us. We'll know the numbers probably around 10 o'clock this morning, our first cut of the numbers. So unfortunately, I'm unable to report those as yet, but we'll update the board once we've got some more information on that. To give you a flavour, we had about a quarter of our junior docs in last time, so 3/4 on strike. We don't know what to expect this time, but if it's similar numbers, that is going to have a significant impact on services this week. There are a significant number of elective and outpatient services that are cancelled so that we can cover the things we need to cover. The LNC remain constructive. That's the local negotiating committee. The doctors negotiating committee remain constructive in working with us and have been very positive, certainly the consultants and the trust grade docs in working with us. So and we have confirmation that if there's any major incident that the junior docs will come back in. So I think that's pretty much it for now. As I say, I'll take the rest of the report for read, Chair.
Thanks, Steve. Comments or questions from Steve on the CE report? Jackie.
Just any feedback from Professor Whitty's visit? Did we get any? Did he give us any feedback?
Simon's probably best to respond to that, and I can see his hand shot up then as well, if that's okay, Chair.
Yeah. Thanks, Simon.
Thank you, Steve, Jackie, and Steve P. So the feedback. So he wrote an email recently, which essentially was just a thank you for having me, etc. But his feedback to me was that he learnt a lot about virtual wards. He hadn't actually spent any time in a virtual ward that was a real life proper working virtual ward. He'd only spent time seeing the research towards them. So, and also he's writing a paper at the moment about older age and care and healthier living, and he said that he gained useful information for that. He incidentally lives not too far away from here, not quite our catchment area, and so we are hoping to convince him to come back again. But we had a big morale boost with the team that saw him. Really were buzzing afterwards. He was a lovely chap. So he and his registrar thought this was a really well executed visit, and they really enjoyed the places we showed them.
Thank you, Simon.
Right, that's really good to hear, actually, Simon. Excellent. Okay, if there are no other questions on the Chief Exec's report, shall we move to IPR? Steve, did you want to say anything by way of a sort of introductory summary?
Thank you, Chair. I think really just obviously the Chief Exec summary is there, and I'll take that as read, but just really to highlight the context that whilst there are some areas that we need to focus on, particularly length of stay and the ongoing improvement in our 4-hour ED performance, our overall performance for urgent care, cancer and diagnostics is upper quartile or around midpoint. And I think it's really important that whilst we keep challenging ourselves to perform better, we don't lose sight of the good work we are doing, and I'm sure that will come out in the IPRs. Our 23-24 planning is progressing. Damien will touch on this briefly a little bit later on, but our primary aim in that, despite what is going to be clearly financially a tough year for the whole of the NHS, is to ensure that we maintain and improve the quality of care that we offer our patients and users throughout it. Colleagues will update further during their parts of the IPR, Chair, so happy to stop there.
Thanks, Steve. We'll just go straight into the individual items. So welcome again, Sarah. Nice to have you with us. Anything you want to highlight, particularly in the quality and safety report, or shall we move to see if there are any questions?
No, I mean, I'm taking that everybody's read. I can just assure everybody, though, that we are continuing to work on all the areas of risk that have been highlighted within that report, that have also been covered on the summary sheet that you can see in front of you. So that covers COVID infection control, incidents and safe care, falls, pressure ulcers, patient experience and nursing workforce. We've convened a variety of groups now to look at compliance on rosters, for example. We've set up a transitions group for patients who are making that transition for children to adults. There's a lot of the infection control rates are actually steady. We've got action plans around the falls that have been experienced, and we know that several of the issues are down to the sort of super surge issues, but staff fill rates remain stable. We've got a lot of new starters from the overseas programme and new to care starting with us, which is going to be good. It'll have a short-term impact in terms of getting everybody up and running, but it's promising. And also we're going to be looking again at job descriptions, person specifications and recruitment as a whole package, because obviously workforce is a pressure along with all the budget. So I'm happy to take questions.
Great, thanks, Sarah.
Thank you.
Anything for Sarah from anyone? Nikki.
It's on the shimmy, Steve. Are you happy for me to ask that, or we're going to move?
Look, well, let's just hold that until Simon's had a chance to have a word about it. Jackie.
Thanks, Chair. Just a question on the COVID element. Say that about a quarter of cases could be hospital onset. Are there any particular areas where that would apply? I'm thinking maybe is it the design of our buildings that's contributing to that because of the bays?
I think at the moment it is the bays, and I think it's also the super surge areas that have contributed to that somewhat, because there are obviously more patients put into areas where there normally aren't patients. But we do work very closely with Lisa Redmond in infection control in terms of isolating patients and stopping people going into those bays, routine testing, and obviously full use of PPE, wearing face masks and that sort of thing. So if there's anything that I'm not elaborating on sufficiently, I can always get back to you with that. But that's, I think, the primary reason for spread, although it is contained. We remain low nationally, and I think national COVID numbers are coming down as well.
And in terms of our escalation, how have we still got everything open, or are we stepping back from super surge?
So we've had the Conquest Jacqueline Beard unit, I think, has been de-escalated. There are a couple of units there, but everywhere else is still super surge, and extended bed spaces are there at present.
That can't help, can it?
No, but I assume that we're going to be making some plans to de-escalate at some point, which would help ease the pressures.
Okay, thank you.
Yeah. Oh, Steve, thank you.
Sheila, were you wanting to add something to that?
Yes, it's just briefly on the super surge. We made a consistent effort over the last few weeks to pull back from our super surge areas, and they made great gains on that. Yes, last week. So we have pulled back from most of the areas, which makes a big impact, and I'll talk about it when I come to my section. But that's our obviously our aim. The further we're stretched, the more our occupancy is challenged. So all efforts on that, and also coming out of the discharge lounge that was bedded at Eastbourne, and both I'll talk about that in a minute, but the discharge lounge, having that back as a proper discharge lounge will make a big impact. So some positive news there.
Thanks, Amanda.
Thank you, Sarah, and well done for understanding the trust so comprehensively already. So I just wondered, Sarah, if you're able to allude how our mental health patients are managing, because we've had many conversations at Q&S, and I know a lot of work is going on within the ICB context, and I just wondered if there was anything you could bring to light, because that's a concern that we're experiencing.
Yeah, no, I've had an email from someone through this morning, actually, because there's a long stayer at the moment, an additional person who's been in numerous hours. So when we finish this meeting, I'm meeting up with Amy Payne to talk about complaints and feedback, but I've also got a CAMS and mental health meeting soon after. So there is work in plan and progress, and as soon as I've got some information, I can certainly email that info to you and let you know what we're doing, because we do want to, and I know we have a weekly complex patient meeting where there have been safeguarding and mental health concerns, and we are involving all key people in that to ensure that they're referred to the Partnership Trust in a timely way, that they are moved into the most appropriate accommodation in the most timely way, so that they can get and complete the treatment that they need at the right time in the right place. So there is work in progress.
Thank you, Sarah. It will be good to see that progress, won't it?
Absolutely.
Thank you.
Yeah, I'll pass that on to you all.
Thank you.
Frank.
Yes, I'm not sure if mine's at the right time. Mine's about patient experience.
Yeah, I've got patient experience.
Perfect. So two questions really. One related to the sheet, which sort of said that 7 complaints were reopened, and the rationale being unhappy with trust response. And I just wondered whether there was any sort of theme behind reopening of complaints. And the second thing was, I suppose, more of a general question related to whether we were seeing more sort of incidents or complaints coming as a result of pressures through the front door, and whether we were seeing any increase in reported incidents of abuse to staff as a result of, you know, pressures coming through the front door and the strike action and stuff like that. I just wondered whether you could give us a bit of a flavour for whether we're seeing anything related to those issues.
So for the reopening of complaints, I know when people do get their reply, they do have the option, if they're not happy, to come back to them, and they can appeal that sort of response that they'd had initially. I'm meeting up with Amy Payne after this meeting has finished. She's the lead for complaints and patient feedback, so I'll have a bit more information once I've spoken to her. There isn't any particular. Yeah.
Maybe Richard could add something, Sarah.
Thanks, Sarah. Thank you, Chair, as well, if I may. The complaints team sits within my bailiwick. So to respond to your questions, Frank, there aren't, in terms of the reopened complaints, there are no key themes that are coming through in terms of conduct or anything else. They are single individual items where the complainants are just unhappy for a number of reasons. Around the ED pressures and whether we're seeing anything more specifically coming through the front door, we're not. We know that ED is a main site. If we look at where the complaints come from, ED is historically, for a whole bunch of reasons, the place that attracts a lot of complaints. However, we're not seeing an increase or an increase volume-wise or in terms of severity. And I suppose the abuse to staff, I'm not seeing that, but I don't know whether Steve is seeing that through any of his teams, but it certainly isn't percolating through any of the teams that I look after.
I've certainly not had any reports or feedback thus far on increase in numbers of abuse to patients, to staff. I apologise. Yeah, so no, I haven't heard any increases in that.
Steve?
I think just to say we saw some general increases over the entire COVID period. We're not seeing anything over and above or in addition to that's being reported that I'm aware of at the moment. So just to back up those points.
Okay, thank you. Good. Thanks very much. Simon, do you want to just take the mortality paper? There's anything you want to add, or I can open it to questions, at least from Nikki.
So only to say that our RAMI, which is hospital mortality out to 28 days following discharge up until up until December ranked us at 31 out of 122 national trusts. Otherwise, Nikki, ask away.
I was just looking at the shimmy, and there's been a sort of strange jump in it in the last. I think it works in months. I just wondered what would cause that, because we're sort of very used to being jolly about the fact that our blue line is below the red line.
Yes, so I have to say I was looking at the red line, and I'm not sure where the red line comes from, because the target is essentially 100. So 100 is what if we were an average trust with average people, average mortality rate is where we would aim to be. Having said that, it has gone up to 100. There's a confidence interval either side of that, so we're still comfortably within the normal range. I don't know the cause of that. We normally do see a peak in winter months, although looking back at previous winter months, it's not been quite like this. So it's something that I need to look into further. There's nothing that I've seen that I'm concerned about, but I will be able to get data to look a little bit beyond that. So I'll probably be able to get 2 months more data to see whether that's changing or not. I'll look at that in between the 2 board meetings.
Thank you.
Thanks, Nikki. Anybody else with anything for Simon? If not, shall we move on to workforce and people? Steve, interesting numbers around sickness, I thought. Steve, anything you wanted to draw to our attention, Steve?
Yeah, I think just a few points to bring out. Firstly, I'm pleased that this is another report, the second in the row, where pretty much all of the indicators have been positive after some really challenging times over recent months, and in fact into almost years. The only adverse relates to pay. And that's a direct impact of the spike in sickness absence in early January, because there's a lag in the temporary workforce numbers that come through. Steve, you mentioned sickness. It's really good to see sickness is very much down to pre-COVID levels this month, 4.1%, 3.8% without COVID. So that's a significant reduction on last month, and as I say, is sort of back to pre-COVID levels. Vacancy percentage has reduced. I think it's worthwhile pointing out that actually that is at a time when we have seen an increase in the number of funded roles, so some really good work there. And our overall turnover was stable this month, so that's a reduction in the last 4 months. I know that mandatory training and appraisals are a real focus. Here, they've both shown an improvement this month. Appraisals are the best they've been in the last 12 months. They're still not where they need to be. We've set a target that we will be compliant with both of these measures by the end of May. And there's a really, really strong push on this. Job planning, again, just to explain, that has been showing an increase. Typically, you'd expect a reduction in job plans at this time of year as people move on to the new ones. So actually, we believe our underlying position is much more positive than it's been for really quite some time. I'm very grateful to Simon and the team for the work they've been doing on that. Lastly, in terms of the report, before I come on to one other thing, rosters, you will notice that the 6 and 8 week roster completion is looking particularly low this month. That's a direct impact from the industrial actions that we've seen, and we're expecting to see a significant improvement back on that again. Vicky, the chief nurse, is putting in place rostering reviews with all areas again to keep driving this. That's not just looking at the rostering, it's looking at leave, study leave management to ensure we optimise our rosters and resource availability. Final thing, just to come on to very briefly, it'd be wrong not to mention it, is the announcement in the budget around the change in pension rules for lifetime and annual allowances. This effectively removes some of the significant challenges that we had with some doctors not wishing to work additional time because of the challenges that led to in terms of taxation on pensions. We are already starting to see the impact of that, and certainly I think for now, whilst we've had questions at board before about recycling schemes for pensions, I think with those changes in the budget, we can park those for now as the issue has been removed. That's all I would want to cover open to questions, Chair.
Thanks very much, Steve. Questions for Steve? No. Okay. Thanks very much for that report, Steve. And yeah, it was very encouraging to see some the continuation of some good indicators in there. Let's move to access. Sheila, anything you want to highlight from your performance report?
Thank you. So I alluded to a couple of things earlier on. One thing I do want to bring up is the reduction in length of stay, which is something we've been talking about here more than once and in other committees. The real key for us is if we can reduce our bed occupancy by pulling out of some of our super surge areas, some of our escalation areas, it gives us greater potential to be able to create flow, which then brings down length of stay, and it has a direct impact on a number of other areas, including our ability to progress with the elective programme. So it's encouraging to see that we are starting to see a reduction in length of stay. Finally, these wheels take a long time to turn, so I'm encouraged by that. Not just overall length of stay, but over 21-day length of stay, which, as you know, we've spoken about. We're actually an outlier nationally on that, and we have it's brought with it some additional attention nationally and regionally, but with that comes support. So we've recently had some work undertaken with the emergency care improvement team, who are working with us to understand more on our length of stay, what's actually contributing to it and what's causing it, both internally and externally, partly to do with recording, but mainly to do with how we manage our patients and their onward destination. So encouraging to see a bit of progress there. I also mentioned we discharge lounges, so you'll be aware that we had, it's probably not for this board, it's due to report next time, but I felt I should share with you, we've managed to come out of bedding our discharge lounge at Conquest site, which means that we can automatically use the space the first thing in the morning to move patients who are going home that day straight there, which gives us early morning flow. And in addition, we were able to obtain some capital money to develop a discharge lounge at Eastbourne site, which has been a very long time coming. I know many of you have been after this for some time. Delighted to say that is now open and has been taking patients from the very beginning of April. It's a fabulous facility. If when you are next on site, please ask to go and have a look around. The team looking after it are suitably very proud, and I think Chris and his team should be also very proud that they turned that round in a spectacular time within budget. So yeah, delighted with that. That again will give us early morning flow. The only other thing I wanted to raise, and I'm happy to take questions on any of the report, in addition to saying thank you to the to our consultants and SAS doctors in terms of the way they have responded to the strike, I think we really should be recognising what an impact this has on all our staff. There's some very, very junior booking staff who have worked tirelessly in order to help cancel and reprocess huge numbers of patients. Many of us have been down to meet them. They do this without grumble. They put in extra hours. These are very junior staff, but they take it really responsibly. Those of you who know the staff will know what I mean. They really take this really to their heart when they have to cancel and then rebook. So I think we need to recognise throughout the organisation at all levels the effort and the impact on people individually. Operationally, the teams are everybody pulls together. We do it very well, and as an organisation, I think we should be really proud. But I think it has an impact. And these are staff who then go home and have to listen to, well, why is everybody on strike? What's going on? And the impact on them with those conversations with the friends and family. I know all of you will understand what I mean, but I think we should recognise this won't be just for this week either. The impact will go on for some weeks. I'll come off my hobby horse there now, but I think I wanted to make sure we recorded that. And then, yes, happy to take any questions from.
Yeah, thanks, Sheila. And you're quite you're quite right to mention that group. I mean, they're unsung heroes at the best of times, and they have to put up with a lot when they're cancelling and rebooking. So yeah, over this particular period, they're doing an amazing job, and I'm glad that you've passed our thanks to them, and maybe you could mention that to them when you see them. Jackie.
Thanks, Chair. Just two questions. One is the continual increase in our waiting list, which is looking like a difficult future coming with given the circumstances. And I was just wondering if there's sort of a medium-term plan for that is more than just an elective centre. And then the second one is the cancer 62-day, which is dipping. And I wondered accepting everything we're saying about the context in which we're trying to operate, is there anything more that we can do?
So yeah, absolutely, and we do take this very seriously. It is quite, it is worrying. We've got a challenge there. We've already had a big challenge to recover from COVID, and now additional impact with industrial action. But a piece of work going on to maximise our ability to put more cases through theatres. You know, there's been some theatre improvement work going on. That's now going up a upper level, I'd say, in terms of pace. And somebody working directly to me, Joe Dale, has been working with the teams on elective to see what we can do to maximise our ability, so that the capacity we already have, that we use it to its fullest. And I think we've recognised there is some space there for us to go. We're also working hard to get some support from the ICB to see where else they might be able to support, whether or not we're able to bring in or access some more off-site capacity through other units who might be able to take some of our patients. So we'll have to do a huge amount of work to recover from where we were. So I'd say it's probably worth us bringing something back in a couple of months in terms of the progress on that and how we're doing with that, increasing our capacity there. The other area we need to really focus on is reducing the number of follow-ups for our outpatients, because we are, whilst we need to increase the number of patients we see, reducing the overall number of patients who have additional follow-ups has a direct impact on our ability to increase our new outpatients. Then in terms of the cancer recovery, again, it's very tight, and every month we are working really hard on those to make sure those patients are processed. There's again more work to be done to work through some of those capacity issues, particularly utilisation of theatre, in order to increase our capacity there. And again, that's work that Joe Dell is championing. She's also doing quite a bit of work with our service managers and general managers in terms of additional training and knowledge on how best to become more effective and more efficient in the way we use our resources, which I think has gone down really well with the teams in terms of that experience she's brought with her. I've forgotten, actually, she came to the board previously, didn't she, to talk. So you'll be aware that her approach to this is quite it's quite rigid and focused to ensure that we get through those patients.
Okay, thank you.
Thanks, Jackie.
Amanda.
My microphone is not doing what it's meant to do. Thank you, Sheila. It was actually on the cancer waiting list that I was just perplexed on our 2-week standard, because of course we've had a relatively good time and there's been improvements in that. But what happened when our referrals were down and our compliance was way down? What happened during that period? And are we confident that we've addressed the issues?
So I need to come back to you with a bit more detail on what was on the actual what was happening. I'm confident now that the processes that Joe has put in place and the rigour in which she is challenging on a weekly basis in terms of a direct challenge with the teams on compliance and ensuring that they're following the correct coding, the correct procedures. So I'm confident now. In terms of the detail on that, I think we need to probably come back with something. I can come back to you directly, Amanda, if that helps, in terms of what caused that dip and confidence. You need the confidence, absolutely, that this won't happen again.
Yeah, it's about the processes that support that and linked to Joe's work, but it would be really good to have some assurance that variability, which we sustained for quite a long period of time, is not going to reoccur.
No, absolutely. And I think Joe's concerned that she provides that assurance that we don't just get along because it was all doing fine before, that we actually have those clear processes in place, and that's what we want to make sure we do, so we don't have a surprise like that.
Yeah, thank you, Sheila. Thank you.
I wonder whether both Amanda and Sheila, next Q&S might be a place to just talk a little bit more about that in a bit more detail, get under the bonnet a little bit.
Certainly.
Yes,
thank you.
I'll ask Joe to produce something. Thank you.
Thank you.
Okay, thanks very much, Sheila. Let's move to finance. We've got this also as the next substantive item for the 23-24 budget, Damien. So it's your bit of the show now.
Thank you, Steve. Can I just start with a brief summary on where we got to in month 11, and I will just touch on the fact that we've obviously just closed the year end, so I'll briefly touch on how month 12 is going, and then can I summarize the current position in terms of the budget for next year. So in month 11, we were still predicting break even as an overall result for the year. In high level terms, the key component is that we're still being supported partly because on the income line, partly because that we have not lost any income from ERF, because our activity is less than originally planned on ERF, but we're getting in total about 5 million benefit from that. We also are receiving additional funding for drugs, although that has a corresponding cost impact, and we also have released reserves over the 11 months of some £3 million. To balance that, we have year to date overspent against plan on pay by 4 million and on non-pay by 4.2. The non-pay actions are obviously partly driven from inflation, and we have seen some additional costs specifically on utilities. That's probably worth highlighting, and clearly there's also been an impact from the high cost drugs, which we've also seen on the income line. So we will, and given we've just closed month 12 as well, I'm confident now that we're going to declare break even for the year. However, that's with using more reserves than we had anticipated. So we're going in next year to a position where you can expect, month by month, it's going to be harder to maintain the position, because basically any shocks we receive month by month will come straight through to the actual result we declare. In terms of the balance sheet, it's worth highlighting that we're trying to close down our capital spend, and I just want to highlight one figure for you. We're trying to deliver by the end of month 12, 39.2 million total capital spend. And by the end of February, we'd actually only spent 19 million of it, which leaves 20 million to be spent in the final month. Just to give you some appreciation of, we still are facing issues with relatively backloaded expenditure and projects that were signed off at the beginning of the year, and therefore the big costs coming through at year end. Can I link that to just highlighting our cash position is still relatively good, and our cash position is partly positive because we received a big settlement 2 years ago that dealt with cumulative balances. So, however, it's not an issue of the trust holding on to reserves. Any cash that we hold gets counted towards the national and NHS cash position. So don't look at it as spare money. Our focus is still delivering our I&E position. So just going back to the I&E position, I think the other point I want to make is while we are delivering break even, that's partly from the fact that we have not been penalised from the ERF position, and also there is a concern that's coming through at year end that has not been delivered through delivering CIPs. So if you look at the savings plan for CIPs, what we actually have is quite a significant reliance on non-recurrent CIPs. So our total full year plan is to deliver 22. Our actual expected delivery is 17 million CIP, so 5 million short of our target. And of that CIP that we're delivering, only 9.6 million is recurrent. I just want to make that point because when we touch on next year's target is 28.8 million against a current recurrent delivery of 9.6. And I apologise for repeating myself, but I think the point just has to be made. I'm sorry.
So can I suggest we stop on 22.3 at that point, Damien, before we, and that will give colleagues an opportunity to ask any questions before we launch into the joy of 23.4. I mean, when we formally get month 12, I will say this again, but I think notwithstanding the points that you've made about how we've got there, I do think that delivering balance, again, this will be the 4th year in a row, is a fantastic achievement. And although it's true for, the point you made about ERF, for example, is true, that's equally true of all other acute trusts, many of whom have struggled to deliver balance, including, a number of our neighbours. And if I were even more cynical, I'd say, well, that was only our money that was taken away from us in the first place to be given back as an incentive payment. So I'm not going to let that get in the way of what I think overall is really good performance. You're obviously right to draw our attention to the kind of structural difficulties that leads us into in 23.4, but I think it's still a significant achievement, and I don't think, in due course we shouldn't let that pass without that being properly acknowledged. Before I open it up, Damien, could you say just a little more about capital and where you think the capital number will finally land? Because I think when we were at F&P, forgive me if I'm not remembering this correctly, I thought there was some confidence that we'd be able to account for all bar about 2 million of the spend. Is that no longer the case?
Yeah, and I'm sorry if I might have sounded over dramatizing it. What I'm talking about is the sheer scale of invoicing we have to process at the year end to be able to deliver this. We're still expecting, we have made the 2 million adjustment in these figures, and we are expecting to deliver the rest of the plan. To be fair, some of it, in particular, the elective hub, we always knew was going to come right to the wire, and basically we can't actually sign off the building until the building's completed. But sorry, not the elective hub, the PSDS3 work, and when you come into the site, you can actually see that it is basically it was completed at the end of March. So just to focus on that point. Yes, so most of these all of the work that is identified, with the exception of the 2 million that we've already adjusted, we are anticipating completed at year end, and yeah, that is an achievement. And also it's worth flagging that we have agreed a plan for next year. And we are trying to move towards having a 3-year plan. It's just we have not quite completed those stages yet.
Okay, well that's good, because I almost had palpitations when you described it the way you did. Let's open it up for questions on what is now last year's numbers, if there are any. Colleagues perhaps saving their powder a little bit until 23-24. Karen.
Thanks, Steve. Notwithstanding the good results in terms of balancing the books and things, can you comment, Damien, on the temporary pay costs? And I guess it's a little bit forward looking as well. I mean, that's a large red number there. And given the year that we're looking ahead to, how do we think we're going to reduce that?
Okay, so the year-to-date figure of 11.5 million temporary and 11.3 million locum and 2.7 million WLIs. The positive message first is we think we are in line with the national limit for next year of total agency spend. However, what's important for us and will be key to savings for next year is finalising the establishment and holding tighter controls on rosters, and that is work that we've all done, and Stephen, Vicky and I have been quite close to this over the last month, to make sure rosters and establishments are closely aligned as we go into next year. I think it's also important for us to recognise the proactive work that needs to happen to maintain this. So, for instance, the overseas recruitment, we're trying not to turn off as a way of maintaining staffing going into next year. So it's those two factors that we need to drive. Steve, do you want to add anything to that?
Yeah, I mean, I think it's just worthwhile reminding ourselves of the year that we've had in terms of both escalation, but also in terms of unexpected, significant peaks in COVID, which have had a massive impact on the workforce, and we've had to use our temporary workforce more than we would have wanted to or have planned to. And we're very grateful, though, that they have actually, come forward in numbers and done additional work or supported that. We are within the 3.7% agency number, which is the nationally mandated number, which is good. We need to work really hard to make sure, and I touched on it earlier, that we've got optimised rosters, we've got optimised holidays, we've got optimised study leave, so that we're maximising the availability of what we have got. And I know that's something that Vicky especially is working really hard on. But I think it would be wrong not to recognise some of the drivers in the previous year, which I hope will not be drivers in the coming year.
Okay, thanks, Steve. If there are no other questions for Damien, I'm going to move on to agenda item 9. And just a governance point before we get into the meat of this. My papers are asking us to approve the revised budget. That what is that correct? That can't be right, is it?
So just to in the national modelling, they have now said that there remains a gap to delivering break even. So there will be additional submissions in April and at the beginning of May. And I think the final target at the moment is the 4th of May, because basically the national view is you cannot sign up to a loss-making budget, at least at ICS level. So I think the purpose of bringing this paper to the board is to say this is the position that we've committed to as at the 1st of April, and we'd expect to roll out the budgets as they stand so that the divisions have something to work to. So I suppose the point, Steve, might be that we're signing off this provisionally on the understanding that the national picture has not yet been completed.
So I think it would be fair to say that we're looking for support for the financial position from the board, subject to the further discussions and iterations that are likely to take place. But we're not at this point formally approving a budget, because would that be sufficient for you, Damien? I don't want to be dancing on the head of a pin here, but I think it's just important to make, just to be clear. Steve, did you want to add something?
I think that's absolutely right, Chair. I think at this point it's recognising and providing support for the progress that's being made, but this is not the sign-off of the budget we're requesting.
No. Okay, and given what we've just said about further iterations, and there are further discussions for us to take place, and further opportunities for board members to look at the detail. Damien, do you want to just add any points you wanted to add to the discussion we've already had? So
I think that's a fair summary. I think it's a pretty clear brief, so I don't need to work through with this. I mean, in summary, it is presenting a budget which is targeting a 16.7 million deficit, and in order to do that, we will have to deliver 5.2% CIPs, which is basically 28.8 million CIP through the next year.
Yeah. Okay, and I mean that's so I've been at this for 43 years, I think, and I don't think I've ever seen a level of savings at that level. But we've a legal obligation to deliver on an agreed financial target, and so I know that exec colleagues are working hard on a programme that will get us to that place as best they can. So let's see what points colleagues might have to make. Frank.
Yes, thanks Steve, thanks Damien. I think I agree that this is a sort of point in time we've still got work to do, and some of the underlying assumptions we just need to make sure we're all understanding and comfortable with as much as we can be. I guess the question for me is that this is really focusing on our budget, but obviously we're in the ICB system, and there are issues that are partly in our control, partly outside of our control. And I just wondered whether it was possible to say a little bit more about how the system in its widest sense was responding, particularly around things like expediting discharge and preventing admissions, that sort of stuff, and how that might then create some space for us as we go through the year.
I think that's a well phrased question. I'm just trying to work out how much I can say on that. What we have got is we have further iterations in terms of trying to improve the overall position, and we are certainly looking at anything we can do to improve flow, because that's clearly one of the underlying drivers. What I would say is, as a system, our system is not yet in balance, therefore that there are additional rounds that the system has to be able to review. I'm not really, Sheila, I'm wondering if you're able to come in to talk about further work that's happening at the moment in terms of improving flow.
Yes, I can certainly do that. I think the reduction in length of stay, so the put in terms of our planning, is based on current work going on. I'm actually more optimistic that it'll be greater than that, and that would actually have a bigger impact on our budget reduction once we get the momentum. However, we've been fairly cautious because our overall length of stay had gone up so significantly that until we can reduce our occupancy, I'm not convinced we are yet on a roll in terms of reducing our overall length of stay. What we will be doing, though, is working with specialties on, specialty reductions in length of stay, where we can, work with them on, for instance, increasing the capacity of the virtual ward, which would then have an indirect impact on, say, respiratory patients for their length of stay. So there are pieces of work to be done individually that will have a direct impact on our length of stay, which would then give Damien the assurance in particular that we will then start to bring that length of stay down. Because once we can do that in a consistent and longer term way, that's where we can actually pull out properly from super surge and our additional capacity in a sustained way. We can actually shut the door behind it. At the moment, we don't have that confidence yet, and as you know, although we've come out of super surge recently, the chances are we will go back in fairly soon until we can make those improvements on our length of stay. I'm not sure I've given you enough confidence that it's perfect, but you know, there's work to be done in a number of these areas that will have that longer term impact.
And I think Jo is the NHS Sussex lead for discharge. Right. I think Sheila, isn't she? And yeah, so I think there are pieces of work that are taking place across the ICS, but essentially that and this is the right thing. Nobody's expecting the ICS as an institution to help us solve these problems. We work together with colleagues across the system, including ICS colleagues, to try and find mechanisms to make improvements. But you know, in a sense, we're all the ICS, and we, you know, it'll be our collective efforts that will make those kind of improvements that Sheila has just described. Amanda.
Thank you. Well, I can't compete with your 43 years, Steve, but I could do nearly as much. I think this is a very difficult position. That doesn't need saying, I know, but I think it's really important that we link this back to the conversation that we had earlier in the meeting, which is, what is the ICBP plan? What's our strategy at place? Because that is where we're going to get most leverage. And at this moment in time, I know the executives are working on this, but I think we need concrete plans to come back as soon as possible to give us the confidence. My only hope is that, as Sheila has repeatedly said during this conversation, we need to get out of those escalation beds. Those escalation beds are built into our financial plan. They cost us in so many ways, and I think that is the area of focus through all the ways. But I do believe we are the ICB, we're part of that ICB. We need to manoeuvre and facilitate change at place in a way that we haven't done before. So I'd like to see more focus on our community services and less focus on beds as an enabler to that strategy. So, Chair, I have no great gifts, but I think we really do need to see some more concrete plans that are different.
Yeah, I agree, and I think if Jo were here, she would say much the same thing about place, because I know that in the conversations that she and I have had, I mean, we would both have liked to have seen progress on place, given where we in East Sussex have been, and frankly, I you know, these are my words, not Jo's. I sort of feel as though we've been treading water for the last couple of years on place, because because of the way in which the structure is organised. Let's say
that's
that.
my feeling too. Yeah.
Steve.
Thank you. So I was just going to come back to the point you made earlier, Steve, regarding Jo being the lead of the discharge work stream. I think it's worthwhile saying that at the system level, there's a whole number of work streams now which are planning to cut, which are planned to come together and deliver, I think, what you're asking for, Amanda. So I think it'll be important as a board that we are not just updated on what we're doing, but on how each of those work streams comes together to shape things. But I have more confidence, I think, given each of the work streams and given the cross-system working, that we are heading in the right direction on that.
Right, thanks, Steve. So there are further conversations to take place, including today and including at F&P and including in other places. So I think what we do is note and support the conversations that exec colleagues have been having so far, note the scale and the size of the challenge and the risks associated with all of that, and reiterate the determination that we've had, that we always have, to deliver on our responsibilities, both to patients but also to taxpayers. Okay, shall we, if everybody's happy, can we move on to agenda item 10, Simon?
I'm sorry, happy to take questions. This is the Learning from Deaths dashboard. Yeah. In the last quarter, there were no avoidable deaths. Happy to talk about the process if people wish, but I'll take it as read.
Anything anybody wants to raise with Simon? No. Okay, great. Thanks very much, Simon. Agenda item 11 on maternity. Brenda, welcome, Brenda.
Good morning. Again, happy to take the paper as read and to take questions. This report just provides assurance around two areas, which is the Conquest and Eastbourne inspection, which took place on the 19th and 20th of October, and the action plans which have been attached, and the National Maternity Services Survey benchmark report, again, which was published in January 23. Sorry. The trust overall for the CQC was assessed as good for well-led and requires improvement for safe. Actions, there were 2 must-dos for Eastbourne and 4 for Conquest. Positively, all actions are progressing well. The action plans included a robust plan for the recovery of maternity mandatory training by the end of May, and as you can see, that is progressing. Appraisals are increasing. We have a stretch to aim for over 90% by the end of May, again, as Steve alluded to. We've had an increase of 4.2% from 68.4 to 72.6% at the end of February, so good progress so far. Technically wise, the Birmingham symptom-specific triage system for maternity was introduced into our services on the 13th of February and is progressing well. We've had no concerns, and this allows birthing people and women to be assessed who come in with unexpected pregnancy concerns, to be assessed and triaged within 15 minutes and then seen as appropriate following prioritisation. Longer term recruitment is being reviewed, and again I've worked with HR around that. I'm pleased to say that we have actually recruited all our trainee staff again for this year, who will commence in post between August and October this year. And we've also recruited 5 whole-time equivalent staff from other out of area as well, so London, who and we've certainly had some of the non-execs and the execs on our listening events in the last month or so. And whilst it's still difficult, we've had the new staff saying how much they enjoy working for us, which is really good news.
That's great. Thanks, Brenda. And the report has been to Q&S.
Yep.
I think I had a nice time meeting the midwives both at Conquest and Eastbourne in the last month. And some very interesting conversations about challenges and issues and how we take things forward. All very good. Let's see if there are any questions from colleagues. No, good stuff. Thanks very much, Brenda. Keep up the good work, as I know you are. Let's move to agenda item 12. Richard, on the BAF.
Thank you, Chair. This is the Q4 update to the board. It, just for governance purposes, it has already been through executives, it has been through the relevant committees, and it has also gone through audit. So it is presented here for assurance, but more for information. So I'm happy to stop there and take any questions, Chair.
Right, thank you. I sort of feel as though the BAF is a bit like the Forth Bridge. You know, it's not something that you ever actually finish. You just keep talking about it, which is as it should be. Nikki.
Very much in that vein, I just wonder whether BAF 5 needs updating, given what next year looks like. I just wonder whether 16 is a big enough number.
So I think you're absolutely right, Nikki. And one thing that we're taking to Stratcom for next year will be the 23-24 BAF, because obviously the BAF risks are the BAF risks for a given year. It's fairly manufactured, but it's a 12-month timeline. And I think what we're looking at, and this may preempt some of Carrie's questions, I'm not sure, is we are talking with NHS Sussex as well about what we would like to see in terms of how we reflect structural issues within the BAF. So I think the BAF scores will be obviously reviewed for 23-24, and what we may see is that while the risks themselves may not change, the scoring, the rating, the mitigations may need to reflect the realities of the year that we're moving into.
The risk number should be perhaps 25, given the conversations that we're about to have, but we'll see. Carys. Oh, sorry, Frank, I think was next. Apologies.
Oh, I'm happy to defer to Carys, and then I can pick mine up. Mine's more process.
Okay, Carys.
Richard, I'm enjoying the fact I'm becoming predictable when it comes to the BAF. I think it makes it fun for both of us. Mine was more of a step back and reflect question, and it's not dissimilar to the one I raised in the last board that we had, which is when I reflect on our financial position, and there's reasons to hope in the IPR, but there remains some real reasons to be concerned in terms of what we're doing as a trust and position we find ourselves in. And does the BAF really reflect, when I step back, the risks as they are today and going forward, especially some of the scores? So for example, in POD, you'll have noticed that we put our scores up because we were concerned, and it was a unanimous decision as a subcommittee. I just think there's an opportunity, and if we're doing it through strategy committee, I'm very supportive. I'm happy to do that under Jackie's care. But if there's anything I can do to support you, just to go through that step back position to say, board assurance framework is very important, and it's important that we as a board say, these are the things we're generally concerned about, and these are the areas of focus for us.
Totally agree, Carys. I think The other piece of work that we'll be doing, again, we're taking it through Stratcom, but we obviously need to refresh our strategic objectives for 23-24, and out of that review will flow the associated risks, because again, the BAF is about the risk that will prevent you from delivering your strategic objectives in a given year. So I think if we take those two items in tandem, what that allows us to do is that step back. Are these the real killer issues for the organisation, as it were? And we can get that sense of perspective and using Stratcom to do that.
And making sure that we've scored them appropriately to reflect the position we find ourselves in and the immediate risks we're facing. Thank you.
Great, thanks, Caris. Frank?
Yes, thanks. It sort of links to that. It looks like we're reviewing the BAF in the first quarter of the financial year. And I just wondered whether, in terms of looking forward, we should be reviewing the BAF in the last quarter of the financial year for the next financial year, just so that we're sort of bringing the in-year risks into that slightly more sort of longer term sort of review. So it's just a process point, really.
Frank, you're absolutely right. And I think we have this battle every year, which is in the olden days when the business plan and the planning guidance and framework for the whole of the NHS was concluded on the 31st of December, it sort of made planning a little bit easier. But I think in the last couple of years, certainly post-COVID, those dates and certainties have kind of drifted a little. So absolutely right. What we'll be looking for next year is a sense of guidance that we can take from the centre that allows us to bring that review earlier, because you're absolutely right. What we wouldn't want to be doing is finalising this later rather than sooner.
Yeah. Sorry, can I just come back? So I think the national planning guidance is one thing. It's never going to say, here's all the money. So there will be some core assumptions that we would know early, and things that we feel are in our own gift, I guess. And so therefore, I wouldn't wait for the national planning guidance in that sense. We can put some assumptions around it.
Yeah, hear that. Yeah.
Nikki?
Yeah, I think I just wanted to sort of second Frank's point, actually, which is, Richard, I think our focus should be on using this BAF as a tool for us to manage our business. So we should be getting to this board meeting in the beginning of April and using the BAF as a tool to look forward and say, what are the organisation's sort of most significant risks for the next year? And I don't think we're dependent on the centre to do that. You know, we already know, we don't know the precise number from the centre, but we know finance is tight. We can look at our staff and understand what the greatest risks are there. So I think I would like us to see us just be a bit more proactive about how we're using this document and make it a useful tool.
No, I totally agree with that. And I would push back to the committees to say that actually, given that each committee is assigned and aligned with the various risks, let's see how we can support the committees going forward to make time in their agenda to review not just the closeout in Q4, but bring forward that review of Q1. Happy to do that. Yeah.
And I suspect if you had your substantive AD for governance, we might have been able to move that on a little bit faster than perhaps we've been able to. Final comment from Amanda.
Yes, I don't want to prolong the discussion, but I need to. So support what Nikki and Frank has said, and I don't think it's just up to committees. I think the board needs to be looking at the risk appetite and also how the BAF aligns to that, given that we are absolutely walking into a different year. And if you just look at the BAF risks, you know, these are it's a board assurance framework. It can't be done, in my opinion, solely through committees. Committees have a role, but this is absolutely about our appetite, and we're going to have to make some quite distinct decisions over the coming year.
I'd fully agree with that, Amanda. Absolutely.
That's a very fair point, I think. Okay, thank you. Let's move to annual self-certification.
So
Richard,
this is
anything?
Thank you. This is in an industry beset by acronyms. This is remarkably clear as to what it does. Every year we review and we certify ourselves against the provider license criteria. So I'm not going to. It is what it is. I'm happy to just present this to the board and ask for your support with this.
Everyone happy with that? Richard, is there a particular committee that owns this or not?
I think it, Pete, is there a particular? I think it comes to the board, but Pete, do we take it through a particular committee?
We normally take it through the audit committee, Richard, but I don't think we've done so this year because of the new guidance that's come out for next year. We waited for that to be released to see if it had any implications for this year's annual self-certification, so it all got a little bit compressed.
Okay, so this time next year we'll be receiving something that's been
audit,
been scrutinised by audit. Okay, okay. I'm not seeing anybody raise any concerns, so so that's formally signed off. Thank you. Agenda item 14, Richard.
Thank you, Chair. This is the briefest of all the items. It's a verbal update, or it's a verbal request, so I'm asking the board to delegate approval for the 22-23 annual report and accounts to the audit committee, and the board will receive our final annual report and accounts to the AGM in September.
And we usually do this, don't we, Richard? This is our normal procedure, so.
Exactly.
Everyone happy with that? Take silence as agreement. Thank you, that's approved. There's information on the use of the trust seal in what has been the last 7 weeks in this particular case for information. If there are no questions on that, that's the end of the substantive items. We have some time now for questions from members of the public who can put their cameras on and come off mute. Liz.
Oh, hi there. Thanks for allowing me to join the meeting. Just want to make it clear, I'm not now chair of the Save the DGH campaign. That's now finished, but I am chair of a local GP practice PPG, patient participation group. So it's more of an overview of not sort of focusing on maternity in the hospital, but generally the system, which is very large.
You're a glutton for punishment, Liz. There's no doubt about it.
Yeah. One of the things that is a concern is A&E and the process going through A&E. It just seems that it appears to be a bit chaotic, and I didn't know whether or not any improvements are going to be made. To me, just as sort of member of the public and also knowing some patients, when people arrive at A&E, it seems to be, I mean, 111, even if you're booked in at 111 to see someone, it normally says, no, you still got to book in. So it doesn't seem to be there's any liaison there. Also, if somebody's suspected infection, it still seems that even if they're triaged fairly quickly, to get antibiotics, it seems like it takes a long time. I know one, it was actually about a couple of months ago, but it was, 14 hours before they got antibiotics, which then the infection was worse and needed, well, I think they were going to be hospitalised anyway, but they wanted to identify the infection. But to me, it seemed like they needed antibiotics, straight away. But anyway, that's a medical thing. But it just seemed in A&E, it was just massive, loads of people there, not enough spaces. And yeah, anyway, so A&E, just the process going through A&E. That was one thing. Finances, no member of the public understands finances of the NHS. I think, we just have to rely on people like you who oversee it, and particularly the non-execs. One of the things would be quite helpful to say, though, are we similar to other trusts? Are we good, better or worse? Because to go into the detail is quite difficult to understand. The next thing is about the new buildings at Eastbourne. Are they sort of part of the new hospital of Eastbourne, or is there going to be a new hospital at Eastbourne? And And the other thing about asbestos work that's carried out, I assume that's got to be done. And is that going, because that's obviously quite costly. People are asking questions about that, which again, I don't really know the answers to. Maternity is still an issue regarding support for women. It doesn't appear to be any better having the all maternity at Hastings. It seems worse to the Eastbourne side of the patch. And with the new hospital, again, that be something to be considered. Is there a shortage of midwives still? How do we fare, you know, locally and nationally? And I think that's it.
How do we compare with others in financial terms? I'm going to have a go at answering that for you, Damien. So the answer is, if you take 22.3, which is all we can judge on so far, I think our performance has been one of the best in the Southeast. A number of our neighbouring trusts have all got year-end deficits. Some of those are really very substantial. So I think we've done extremely well. We know that Sussex Partnership have had problems. We know that UHSX have had problems. We know that SASH, just on our borders, have significant problems. We know that even Queen Vic has had some problems, but the scale of their problems are because their budget is smaller. You know, the numbers are smaller. So I would say that we are doing as well as anybody and better than most, would be my summary of it. And I'm not even going to ask Damien to comment on that because I'm not. So Sheila, A&E.
Yes, so thank you for the question, Liz. And actually, as an interim winter director, I have the privilege or challenge of working in a number of organisations around the country and have done over the last few years. So in terms of how we're doing compared with others as well, I see what you're referring to in terms of chaos in the EDs generally. And some of that is to do with large numbers of patients. We are trying to the word process doesn't sound quite right, but trying to arrange to get to the right level of treatment for each and every one of those patients. And I believe it's been a challenge for the majority of A&E departments across the country in recent times. That's not a cop-out. I'm just trying to compare like with like. I think the chaos that you're referring to actually relates to streaming, the way we stream our patients and the way we organise patients who attend the hospital either of their own volition. They've turned up because they believe that's the right place to be treated, and it may not be, and we need to actually improve with our ICB colleagues in directing patients to the most appropriate place. And that has been a challenge. It continues to be a challenge for us, but getting the messaging out to the public to not come to A&E just because it's open, it's the only place open. There are a number of other places to access really good care, in particular pharmacists. Going to get really good advice from pharmacists who are available. That would help. So there is work we can do with ICB to improve where people attend for their treatment. But once they are on site and in our A&E, streaming them to the right level of care and the right area to be treated does require improved organisation. We're doing a piece of work in both our A&Es at the moment as an improvement piece of work on how we manage our patients and where we process them. And so hopefully you will see the benefits of that over the course of the next few months as we improve where we're directing patients. We also have introduced some new ways of allowing patients to access direct consultation with Livy doctors who are provide a consultation. Some of your colleagues will have discovered when they go to a GP they can access Livy, and we're actually doing some work with them at the moment to see if we can improve access for patients who don't actually need to be in ED but need to be seen there and then. So that will be coming online soon. In terms of the delay of that specific patient in terms of waiting for antibiotics, I can see why that would that's frustrating, isn't it? Because if you can initiate treatment straight away, then the antibiotics get in quicker. However, part of what we do in ED is to triage our patients so that the most needing immediate treatment get that treatment, and it does mean that then some patients will wait longer because they're not deemed to be as high a priority for immediate treatment, and that can add to the delays. And we have seen excessive delays for many patients in recent months. We saw it through COVID as well, where patients are waiting a long time, and that is work that we find very frustrating. The staff indeed also find that frustrating because they have a very crowded department at that time, which makes seeing those patients in a timely, organised way more challenging. So they are very fair challenges, and I'm really glad that you're part of our our board conversation, because you bring us back to what's important to patients, what's the impact to them and their experience. So I'm happy to have a chat to you separately about the improvements we're making, but I think safe to say it's not how we would wish it to be either, and we want to make improvements as we go. Having said that, we do sit well compared with other organisations around the country, and we continue to want to move towards the upper quartile for that. That's exactly where the board would wish us to be. So that's where we're aiming for. Hope I've answered what you need, but more than happy to have another question.
Can I just add just a comment to it? It seemed to me that people that were in contact with me were, if they went on 111, either online or on a call, they were sent to A&E, and I'm not sure that they should have gone there. Not that I'm medical, and I just think there might need to be conversations had with 111, because it definitely, in the people that got in contact with me, I would say at least half shouldn't have actually gone to A&E. I'm not medical, but I would have thought they could have been redirected.
And you're absolutely right, Liz, and that is an ongoing challenge for us, that the way the algorithms work in 111, we do need to work much more closely with them through the ICB to help them direct patients to the right place. As you say, quite possibly those patients should have gone to urgent treatment centres separate from our organisation, where they could have been treated quicker and more effectively, and allowed someone else to have the space where we are. So very good observations, and I will feed that back into the ICB, where they will be able to have that greater influence on 111. Thank you.
Steve, do you want to just say a word about the National Hospitals Programme? And then I'm going to draw us to a close, even though I'm mindful that we've not covered maternity, but I'm anxious to give exec colleagues an opportunity to get out in the wards and see how things are in the middle of the strike. Steve.
Thank you. Liz, just to try and answer that, you mentioned a couple of things there. There are, we know that as a hospital, we have a number of works which we need to continue working on. Our backlog programme is a fairly significant programme. So yes, there is ongoing work around the hospital to ensure that we maintain a safe environment. In terms of if you were get my words out, if you were referring to the new elective hub that's been announced in terms of buildings, that is part of ESHT. But as you know, we are part of the new hospitals programme, and we are still waiting for an announcement in terms of what we will get, when we will get it, and how we'll be able to use that going forward. So in terms of the impact of that on our estate, I'm afraid we're not able to answer that yet, but it won't be brand new hospitals. The funding won't be there for brand new hospitals. It will be to ensure that we make the best we possibly can out of our current estates.
Thank you.
Right, thanks. Steve. I'm going to draw us to a close. Thanks very much, everybody. I'm sorry if it was a bit of a gallop through today, but we know that we've got a slightly odd set of circumstances today. Our next meeting is Tuesday, 13th of June. As it stands at the moment, that's in Horntide Park complex in Hastings, but we'll see. Thanks very much, everybody.